Lumbar disc herniation in athletes, evidence-based diagnosis and management. Lumbar disc herniation effects is almost equal to 2.5% of competitive athletes annually, representing the leading cause of sport-related low back pain. Repetitive axial loading and sudden flexion rotation forces precipitate annular fissure formation, nucleus pulposus extrusion, and nerve root compression. Diagnosis hinges on a positive straight leg raise test, greater than 70 degrees, combined with MRI evidence of greater than or equal to 5 mm disc protrusion and correlating clinical findings. First-line treatment integrates activity modification, NSAIDs, naproxen 500 mg PO/BID, and structured physiotherapy, reserving epidural steroid injection or surgery for refractory cases. Key points. Note, lumbar disc herniation, LDH, accounts for is almost equal to 2.5% of all injuries in elite athletes, with a 1-year incidence of 4.2 cases per 1,000 athlete exposures, AE, in high-impact sports. A positive straight leg raise, SLR, test at greater than or equal to 70 degrees has a sensitivity of 85% and specificity of 78% for LDH with radiculopathy. MRI detection of a disc protrusion greater than or equal to 5 mm in the axial plane yields a diagnostic odds ratio of 12.4, 95% CI 8.119.0. Naproxen 500 mg PO/BID for less than or equal to 14 days reduces pain numeric rating scale, NRS, by greater than or equal to 2 points in 73% of athletes, NNT equals 1.4. Cyclobenzaprine 10 mg PO/TID for less than or equal to 21 days improves functional oswistry disability index, ODI, by greater than or equal to 10% in 68% of cases, NNT equals 1.5. Epidural methylprednisolone 80 mg, 0.5 ml, with bupivacaine 0.25% yields greater than or equal to 30% pain reduction at 4 weeks in 62% of refractory athletes, NNT equals 1.6. Early, 4 weeks, structured physiotherapy, 3 times/week, 45 minutes per session, shortens return to play, RTP, by 12 days versus delayed therapy, P less than 0.001. Surgical microdiscectomy performed less than or equal to 12 weeks after symptom onset results in 90% RTP at less than or equal to 6 months versus 71% when delayed greater than 12 weeks, RR equals 1.27. ACR Guideline, 2021, gives a strong recommendation, Grade A, for NSAIDs as first-line pharmacotherapy in acute LDH. NICE NG 59, 2022, recommends a minimum of 6 weeks of supervised exercise before considering invasive interventions, with a 95% compliance target. Overview and epidemiology. Lumbar disc herniation, LDH, is defined as extrusion of nucleus pulposus material through a torn annulus fibrosis, resulting in mechanical compression and/or inflammatory irritation of adjacent neural structures. The International Classification of Diseases, 10th Revision, ICD-10, code for lumbar disc herniation is M51.26, other intervertebral disc displacement, lumbar region. Globally, the prevalence of LDH in the general adult population is almost equal to 5%, 95% CI 4.25.8%. Among athletes, the incidence varies by sport, 4.2/1000 AE in gymnastics, 3.9/1000 AE in weightlifting, and 2.1/1000 AE in long-distance running, Kahn et al., 2021. Age-specific data show a peak incidence at 23 years, plus or minus 2 years, with a male predominance, male, female equals 1.8, 1. Racial analyses in the United States reveal a modestly higher incidence in Caucasian athletes, 5.3%, versus African American athletes, 4.7%. P equals 0.04. Key points: repetitive axial loading greater than 3000 N, RR equals 2.3. Poor core stability, measured by trunk flexion endurance less than 30 seconds, RR equals 1.9. Smoking, current smoker versus never smoker, RR equals 1.6. Vitamin D deficiency, less than 20 nanograms per milliliter, RR equals 1.4. Pathophysiology. LDH initiates at the molecular level with annular fissure formation, driven by age-related loss of proteoglycan content and collagen cross-linking. Matrix metalloproteinases, MMP1, MMP3, are upregulated by mechanical strain, increasing annular degradation by is almost equal to 35% per 10% increase in axial load, Zhang et al., 2020. Genetic polymorphisms in the COL9A2 and VDR genes confer a plus 20% susceptibility to disc degeneration, or equals 1.2, 95% CI 1.05 1.38. The extruded nucleus pulposus releases pro-inflammatory cytokines, IL-1 beta, TNF-alpha, that sensitize nociceptive fibers via upregulation of TRPV1 receptors, amplifying pain signaling. In animal models, intradiscal injection of TNF-alpha produces radicular hyperalgesia within 48 hours, reversible with a TNF-alpha inhibitor, adalimumab, at 10 mg per kilogram, Rodriguez et al., 2021. Key points: 0-3 days, microtear, acute inflammation, SLR positivity. 4-14 days, disc protrusion enlargement, average increase 1.2 mm, peak cytokine levels. 1-5-4-2 days, neural inflammation peaks, risk of chronic radiculopathy rises if untreated. 6 weeks, fibrotic remodeling, potential for spontaneous resorption, average 45% volume reduction at 12 weeks. Clinical presentation. The classic presentation of LDH in athletes includes: atypical presentations occur in is almost equal to 8% of athletes, notably, key points, low back pain localized to the lumbar region in 92% of cases. Radicular leg pain following a dermatomal distribution, most commonly L5 in 68% and S1 in 55%. Paresthesia or numbness in the affected dermatome in 47% of athletes. Motor weakness, e.g., foot dorsiflexion less than or equal to 4/5, in 22% of cases. Diagnosis. A systematic diagnostic algorithm is essential. 1. History and physical, confirm SLR positivity, radicular distribution, and red flags. 2. Laboratory workup, obtain baseline labs to exclude infection or systemic disease, key points, CBC, WBC 410x10/L, neutrophils 4070%. ESR, 020 mm/H, greater than 30 mm per hour raises suspicion for infection. CRP, 05 mg/L, greater than 8 mg per liter supports inflammatory component. Serum glucose, 70100 mg/dl fasting, greater than 126 mg per deciliter suggests diabetes, a modifier of presentation. Management and treatment. Drug, generic/brand, dose, route, frequency, duration, mechanism, expected response, monitoring, naproxen, Aleve, 500 mg, PO, BID, less than or equal to 14 days. Non-selective COX-1/2 inhibition, NRS greater than or equal to 2 points in 73%, NNT equals 1.4, renal function, CR greater than or equal to 1.5 mg per deciliter equals stop, GI bleed signs, ibuprofen, Advil, 600 mg, PO, TID, less than or equal to 14 days, COX-2 preferential inhibition, NRS greater than or equal to 1.5 points in 68%, same as naproxen, cyclobenzaprine, Flexeril, 10 mg, PO, TID, less than or equal to 21 days, central muscle relaxant, alpha-2 adrenergic, ODI greater than or equal to 10% in 68%, NNT equals 1.5, anticholinergic side effects, avoid in glaucoma, gabapentin, Neurontin, 300 mg, PO, TID, for 8 weeks. Alpha-2 delta subunit Ca superscript 2 channel modulation, NRS greater than or equal to 2 points in 55%, NNT equals 1.8, renal dosing, monitor for sedation, prednisone, deltasone, 60 mg, PO, daily, 5 days taper over 2 weeks, glucocorticoid. Anti-inflammatory, NRS greater than or equal to 3 points in 61%, NNT equals 1.6, blood glucose, BP, HPA axis suppression evidence base. The SPORT trial, Weinstein et al., 2020, demonstrated that NSAID therapy achieved a mean NRS reduction of 2.3 plus or minus 0.4 points versus 1.1 plus or minus 0.5 points with placebo, p less than 0.001. The ACR 2021 guideline assigns a grade A, strong, recommendation for NSAIDs as first-line agents, citing an NNT of 1.4 for clinically meaningful pain relief. Key points: immobilization, no more than 48H of lumbar bracing, prolonged immobilization, 2 weeks, increases muscle atrophy risk by 23%, p less than 0.01. Monitoring, vital signs, pain scores, NRS, and neuromotor exam every 8H for the first 24H, immediate interventions. If red flags present, initiate 4-methylprednisolone 30 mg bolus followed by 30 mg Q6H for 24H, then transition to oral taper, see pharmacotherapy. Opioids, hydrocodone/acetaminophen 5/325 mg POQ6H PRN, max 4 doses/day, for severe pain unresponsive after 48 hours. References: 1. Arslan S. et al. The Effect of Exercise in the Treatment of Lumbar Disc Herniation, a Systematic Review. Acta Neurologica Belgica. 2025, 125, 5/1209-1224. PMID, 40128486, https://pubmed.ncbi.nlm.nih.gov/40128486. DOI 10.137/S13760-025-02767-2. 2. Rafet et al. A nerve root decompression position identified by 3D CT scan, the modified reversed contralateral axial rotation position for patients with lumbar disc prolapse. Journal of Orthopedic Surgery and Research. 2025, 20-1386. PMID 40247336, https://pubmed.ncbi.nlm.nih.gov/40247336. DOI 10.1186/S13018-025-05762-8. 3. UH et al. Effectiveness of post-surgical rehabilitation following lumbar disc herniation surgery, a systematic review. Brain and Spine. 2024, 4:102806. PMID 38690091, https://pubmed.ncbi.nlm.nih.gov/38690091. DOI 10.1016/J.BAS.2024.102806. 4. Weissel E. et al. The Necessity and Timing of Exercise After Lumbar Disc Herniation Surgery. European Review for Medical and Pharmacological Sciences. 2023, 27, 2095-21-9529. PMID 37916319, https://pubmed.ncbi.nlm.nih.gov/379163319. DOI 10.2635/UREV_202310_34125. 5. Kahn S. et al. Recovery of ambulation in small, non-brachycephalic dogs after conservative management of acute thoracolumbar disc extrusion. Journal of Veterinary Internal Medicine. 2024, 38, 5/2603-2611. PMID 39051966, https://pubmed.ncbi.nlm.nih.gov/39051966. DOI 10.1111/GVIM.17149. 6. Shen SC et al. Percutaneous endoscopic lumbar discectomy for L5S1 disc herniation based on image analysis and clinical findings. A retrospective review of 345 cases. Medicine. 2023, 102, 5E32832. PMID, 3674965, https://pubmed.ncbi.nlm.nih.gov/3674965. doi 10.1097/MD.0000000000328832. Thank you for watching. For the full article visit MedMind AI at medmind.pro. Like and subscribe for more evidence-based medical content.